Hello, this is David. I wanted to present fall prevention in long-term care facilities. Are falls a serious problem? Well, the Center for Disease Control estimates between half and three-quarters of nursing home residents fall each year. About 1,800 people living in nursing homes die each year from falls. 10% to 20% of nursing home falls cause serious injuries, with 2 to 4% causing fractures. And then finally, falls also lead to reduced quality of life and functional decline. Someone breaks a hip, that might be it for them. In my facility right now, the current conditions at work are fall assessments are conducted at admission once a week for 4 weeks. No reassessments done without a fall. Precautions such as floor mats, alarms, lowered bed, keeping the resident by the nursing station, a call light in reach, non-skid footwear, cued toileting, and handrails. These precautions are initiated at the RN and CNA's discretion. There's not really a process for that. After a fall happens, 4 reports are filled out, so lots of paperwork. Vitals and neuros are assessed for 72 hours. Then a group of managers reviews the reports and makes recommendations to prevent the falls. The current conditions continued. There is definitely a lack of continuity in my facility's fall prevention programs. The current program is static. It has no possibility to improvement. There's just no built-in mechanism for improvement. The recommendations that the managers make are almost always in place before the fall, but no communication has occurred between the reviewers and the floor staff. Prevention's very haphazard, much at the discretion of the floor staff, the nurses, and the CNAs. Education is non-existent. There's no training for fall prevention. Implementation. This is what we want to prevent. In a functioning fall program, the staff would be educated to fall causes and prevention. The CNAs, the nurses, just pretty much everybody. Assessment and reassessment would be reoccurring at designated intervals. Review of falls would involve the floor staff, the nurses and the CNAs, as well as management. And finally, there would be cooperation with an interdisciplinary team, including the doctors, physical therapists, dietary, and management. Responsibility. In the goals for the long-term care, the Joint Commission focused on 5 goals within long-term for fall prevention included. The Commission's focused on widespread problems that would have the biggest payoff for limited resources. As nursing professionals, it's going to be our job to recognize and seek out such problems because our resources are going to be limited, and we're going to have to be judicious and wise in use of these limited resources. We're going to have to pick our battles and get the most bang for the buck. Leadership. What can one almost brand new RN do? First, a leader needs to lead by example, and I would have to emphasize fall precautions by individual patients. I would have to ask CNAs for input as well as other nurses. I would adhere to the procedures that are in place currently, and I would ensure my floor staff is in compliance with the current procedures. I have to be a directive in that, but lead by example also. And I think most importantly, I would have to utilize the latest research. I would have to go and look at what research is available, what works, what doesn't. I was surprised that restraints don't work well for fall prevention in looking up research for this project. The leaders, as I said, leaders got to be the one who knows the way, goes the way, and shows the way. Leadership continued. A second part would be an RN such as myself could become a work group leader in the area of fall prevention. And I have quite a bit of experience in this from my previous job, where as a work group leader for developing work processes. What this means is I could lead a group of nurses and CNAs in developing a process or processes that first in problem solving, because there's obviously a problem. We have too many falls. And I would use the group that is most in contact with the floor staff, being the CNAs and nurses. And once we had that in place, we had some of those solutions in place, we would focus on continuous improvement, because you can't just solve a problem and then just let it go. There has to be some mechanism in place for improvement, or at the very least monitoring to maintain what you've already achieved. And these processes would involve the nurses and the CNAs and what we have direct control over, because at this point we just need to fix what we can fix. My leadership role then would have to expand to other disciplines, otherwise the fall prevention goal is basically unachievable, except as a preventive, as an immediate preventive, not long-term preventive. We'd have to involve doctors, nurses, pharmacists for the effects of various drug treatments and pharmacy, physical therapists to strengthen and for baseline evaluations, and management. We'd need them for the resources that we need to implement these programs. And this is similar to the quality improvement process, where you'd have to meet every 3 months. You'd have to evaluate where you were, look for new problems, what can be improved, and go from there. It has to be an ongoing, continuous quality improvement. And that's where I could be a leader as a nurse. This would be the goal, getting up and down with no problems. This is from a song called Falling by Florence and the Machine. It's the chorus to the song, and it's a group that I listen to occasionally. This song came out, I believe, in 2009. It's one of her earlier songs. She's been on the music scene for a few years. Sometimes I wish for falling, wish for the release, wish for falling through the air to give me some relief. Because falling's not the problem. When I'm falling, I'm in peace. It's only when I hit the ground it causes all the grief. And these are my references, and hope you enjoyed the presentation. Have a good day. Thanks.